Hello and welcome to this session of Maritime Medicine, in which we'll be discussing dental disease. By the end of this session, you'll be able to identify each adult tooth by name and number, identify 3 signs and symptoms of a dental abscess, perform a tooth block, treat a dental abscess including incision and drainage, treat a dental fracture and an avulsed tooth, identify at least 4 red flags of severe dental disease, and identify and manage a mandibular fracture. So, just to review dental anatomy, the teeth obviously are in the mouth. They grow into the alveolar ridge, or that's where they come from, so they're stabilized in these bony structures of the maxilla, which is your midface, and the mandible, which is your jaw. And they grow up into that space, and they're designed to provide a mechanical form of digestion by crushing or tearing food, so they occlude with each other or meet with each other, and they form sort of a bony outer rim which protects the tongue and the mouth. Each tooth, as it grows up, has a root surrounded by the bone of the alveolar ridge, and there are nerves and blood vessels that grow into there. They are held in place with something called cementum. In the center of that area where the blood vessels and nerves are is the pulp. Over that is dentine, and then the hard white stuff on the top is the enamel. You can see that all anything above the gum line is your crown and is covered with enamel, and below the gum line is your root. Looking at the images on the right, you see the right-sided teeth. You've got superiorly or maxillary and inferiorly or mandibular, starting on the left going to the right, the molars, premolars, canines, and incisors, and we'll talk more about these teeth. So there's a numbering system. It starts on the patient's top and on the patient's right. So remember, if we're looking at the teeth, what appears to be your left is the patient's right, and tooth 1 through 16 on the top, 17 through 32 on the bottom. And on the right of the screen, we're looking at what each of those teeth are. So you've got your 2 incisors, a central and a lateral, a canine, 2 premolars, and 3 molars, and the 3rd molar is the wisdom tooth, which may or may not erupt. And so if I were describing where someone's tooth hurt, I might describe it as tooth 30, or I might describe it as the right mandibular 1st molar. The mandible is the jaw, and the jaw is the alveolar ridge, and your teeth sit in there. The mandible articulates with the base of the skull at the temporomandibular joint, and it's an interesting joint because it's surrounded by a joint capsule, and it's designed to actually pull out slightly, what's called sublux, and that's so that you can really open your jaw wide, and if you go too far it can actually pop out or dislocate. And if you actually have a patient who's got a lot of pain over their temporomandibular joints, which is, you can feel it on the side of your face when you talk, it's where your jaw moves against the skull, so they have a lot of tenderness there, and the jaw is stuck open. Talk to medical control about how to reduce that dislocation. It's fairly easy to do if you can get the patient relaxed enough, but getting them relaxed enough can be very tricky. So this is the mandible. You can see it's almost a circle, and where it connects to the base of the skull, that whole thing makes it into a circle, which becomes relevant when we talk later about fractures. You can also see towards the front, and particularly on the picture on the lower right, you see that hole in the mandible, and that's where a nerve comes out that gives sensation to the teeth. So to do your dental exam, you look at the face and the cheeks, you inspect them and you press on them. The lips, you inspect them, you don't really have to press on them much. Gums, you'll inspect them and then run your finger along them, both on the inside and the outside of the teeth. The teeth themselves, you'll inspect them. You may try to wiggle them. You'll tap on them or percuss them. You feel under the tongue and look under the tongue. Press on it, palpate it, and inspect it. And then the lining of the cheeks on the inside, you'll inspect those as well, and you'll palpate them. We'll talk briefly about dental pain control. It's amazing how such little things can cause such incredible pain. You typically start with your topical anesthetic, so oil of cloves or 20% benzocaine, which is sold as an oral anesthetic over the counter. Absorb through, block the nerves, improve comfort quite a bit. Oral agents like non-steroidal anti-inflammatories, sometimes narcotics are necessary, and a tooth block or injection of a little bit of numbing medication to block the nerves where they come up through the alveolar ridge and into the tooth can actually also be very effective for controlling pain. Alright, let's start by talking about dental caries or cavities. You've got bacteria all over your teeth, and when you add sugar, they metabolize that sugar into acid. That acid will dissolve the enamel and the bacteria invades into it and you get a cavity. And typically these are pretty asymptomatic. You may look into somebody's mouth, see a bunch of black pitted holes on their teeth. Those are cavities, but they may not have any symptoms until the bacteria reach the pulp. And then the patient gets pain. So on exam you'll see that black sort of drilled out looking hole in the tooth. If they've got a lot of discomfort, so it's reached the pulp, you can give them some numbing medication and they'll need a filling or possibly an extraction on shore depending on how extensive it is. And what's happening is they've got pulpitis, which is bacterial infection of the pulp, which causes pain. The patient will have a toothache, which is always present, but if they eat or drink or they suck air across a tooth, it hurts quite a bit more. You look in, you see a cavity, you won't see the pulp. Treatment is pain control and a dentist visit on the shore. Medical control may also recommend antibiotics, but they don't really change the outcomes particularly unless you can see an actual abscess or infection. So once you have the pulpitis, you can get the periapical abscess, which is an infection in and around the tooth, and an abscess or a little collection of pus forms and it expands in and on the alveolar ridge. So below the gums on the bony structure you can actually sometimes see the abscess. Sometimes it just presents with facial swelling, and early on often that's what you'll see, significant facial swelling, but when you look in the mouth you don't find any abscess that's easy to drain, but sometimes there's a visible abscess as well. So on the left you see that abscess right there on the alveolar ridge under the tooth. That is raring to be popped and drained. Typically what you're going to have as a presentation is more what you see on the right. So a patient has facial swelling. When you examine inside the mouth, you may not find an abscess. This may all be reactive swelling, and the infection is probably under the tooth in the alveolar ridge around the root and hasn't come out anywhere where you could get to it to drain. So the treatment is pain control. You can do a tooth block. If you look at that tooth, if you went straight down below that tooth into where the soft tissue, the mucous membrane on the alveolar ridge turns into the mucous membranes on the inside of the cheek, that's about where the nerve is to the root. So you can do a tooth block there. You may need to give oral pain medications. Talk to medical control about antibiotics. They'll give you their recommendations on what to use, but if you've got facial swelling or a clear abscess, then they do need antibiotics, and if there's a lot of facial swelling they may need to be IV or IM, and if you can see the abscess you may aspirate it or do an incision and drainage. So to do your tooth block, you're injecting just to the outside, sort of lateral or anterior depending on where you are in the jaw, either on the buccal side or the lip side. You're injecting just a small amount of lidocaine in there to block that nerve, and you inject it right where the mucous membrane comes off of the alveolar ridge, the bony structure that holds the teeth, and reflects or curves into the mucous membranes that cover the cheeks or the inside of the lips. So you're going to need lidocaine, about 1 to 1.5 milliliters, and number 27 to 32, so very small needle. You insert it directly into that reflection, about half a centimeter or so, not that far in, and you inject. And you're using such a small needle that even if you tried to pull back on it to aspirate to make sure you're not in a blood vessel, you wouldn't get any blood back. So don't worry about that. Just inject that 1 to 1.5 ml of lidocaine. That turns off the nerve and makes the tooth feel much better. Now, to drain the abscess, the easy way is to do an aspiration. So you perform the tooth block that makes them comfortable, makes the procedure more comfortable. Insert a number 25, 24, 26, 27 size needle into the abscess. 25 is a good size, and you probably want to go a little bigger rather than smaller, so the lower number if you need to, and you suck out the pus. If it's a big abscess, you need to do an incision and drainage. So you perform a tooth block, and then you just nick the top of the abscess with a number 11 or number 15 scalpel. It'll burst open, the pus will go all over the patient's mouth, have them spit it out, have suction ready, have some water ready so they can swish it and spit it and suction everything out. In pericoronitis, if people's wisdom teeth haven't erupted all the way out, as they start to come out, they can cause pain. That's not a big deal. But if the gum flaps get infected, they can form an infected pocket between the gum flap and the top of the tooth. So they'll have pain over the erupting wisdom teeth where they're still covered by gum flaps, and when you examine them, they'll have some redness and swelling and tenderness. Often you'll look and it looks just like everything else, and that's just the pain of the tooth itself moving. But if it's infected, it looks very different there. Treatment is pain control, possibly a tooth block, although they're very hard that far back in the mouth. I find the benzocaine or the oil of cloves topically helps quite a bit, oral pain medications, and antibiotics to treat the infection. And talk to medical control about which ones they want you to use. Dental trauma is pretty common, and we classify it based on the Ellis system of 1, 2, or 3. In an Ellis 1 tooth fracture, it's a crown fracture, and it's through enamel only, so it doesn't go any deeper than the enamel. It's basically a chip off the tooth, and it's typically asymptomatic, or they can tell it happened because they had some trauma or they bit on something, they spit out a bit of the tooth, and that tooth now feels rough to them. It's cosmetic, but your treatment really is none. Or if it's really bothering them, you can take an emery board or a nail file down the sharp edge just a little bit, but there's really nothing that needs to be done. For an Ellis 2 tooth fracture, the enamel's fractured all the way into the dentin, so once you look, it doesn't just look like a broken white tooth. You actually see some yellow discoloration. It's tender to touch and sensitive to the air, and it's at risk for infection and then the tooth dying. So the treatment is a temporary filling. If you don't have any temporary filling, you can actually use Dermabond. That makes a pretty good seal. You just have to really dry the tooth up, put a drop on there. They need to see a dentist within a day or two, and talk to medical control about whether or not to start antibiotics. For an Ellis 3 tooth fracture, which is what you're seeing there on the right in that picture, it's fractured all the way to the pulp. So you've got the pink pulp that you can see in the middle with the broken tooth. It's painful, it's very sensitive to touch, and these are highly susceptible to tooth death. So you need to put temporary filling material over it, a dentist within 24 to 48 hours, and these patients absolutely need antibiotics. Now, without breaking the tooth itself, you can do other things. Remember, the tooth sits in the socket, held in place with cementum, so it's held in that bony alveolar ridge, and the tooth can get knocked out of the socket, sometimes with an alveolar ridge fracture, sometimes with just the periodontal ligaments and that cementum pulling apart. The tooth will die quickly once it's out. So your treatment is to gently rinse the tooth, don't scrub it. Reimplant it in the socket if possible. If you can't, put it in milk or something called Save-A-Tooth, which is a commercial thing, and they need to go to the dentist immediately. In a dental subluxation, the tooth is knocked loose in the socket, and again, there may be an alveolar ridge fracture with it. Here the treatment is to stabilize it to the neighboring teeth. Hopefully it's just that the ligaments are slightly torn. They need to see a dentist in 3 to 5 days, and actually when you put stabilizing material on, which is very similar to the material that you use to make temporary fillings, it binds across the teeth, And in fact, that'll often take care of it, and by the time they see the dentist, it's all healed and better. But they still need to follow up with a dentist. And in a dental intrusion, the tooth that's already erupted is pushed back into the alveolar ridge under the gum, and they need to see a dentist in 24 to 48 hours or they're going to lose that tooth. Now, if you've got a patient complaining of dental disease, if they have trouble opening their mouth, they've got what's called trismus, which is muscle spasm. They can't open up the jaw at all. That's very concerning for an extensive infection. Any difficulty swallowing, and not just a little pain, but I'm having trouble swallowing, or frankly I'm drooling because I can't swallow my own saliva, that's a very bad sign. It often means an infection has spread down into the soft tissues of the throat. If they have difficulty breathing, it means the same thing. If you look at the neck and the neck is swollen, particularly right under the tongue, that's very concerning. We've talked previously in other sessions about Ludwig's angina, the big infection under the tongue extending into the neck. That typically comes from a dental infection in the mandible spreading down, so that's very concerning. And really any pain extending beyond the immediate vicinity of the tooth should at least get your attention and make you think about things. Now I'm going to touch briefly on mandible fractures here. Technically they aren't dental disease, but they can happen with similar types of trauma. They can be open or closed, so cuts either on the outside or in the mouth. And if you think about the pictures you saw, again, with the mandible articulating on the base of the skull, it's really like a ring functionally. So if you get force on one side, you tend to break the other side as well. So the presentation will be of trauma with jaw pain. They may not be able to open or close their mouth. There may be a lot of blood in the oropharynx, and when they do close their mouth, it feels to them like their teeth aren't lining up. And when you examine them, you find tenderness along the mandible, particularly focal tenderness in one area, and usually again on the opposite side you'll find similar tenderness, open wounds in or outside of the mouth, and inability to bite break a tongue depressor. And basically what you do is you put a tongue depressor between the occlusive surfaces on one side of the mouth, so between all the molars and the premolars, the canine on, say, the right side of the mouth, you tell them to bite down and you twist it. And they should be able to bite down enough that the tongue depressor breaks. And if they can't, if it hurts too much or the jaw opens up, you need to be worried about a fracture. If they can, they're probably bruised. It's very hard to bite that strongly if you do have a fracture. And then test the other side as well. And when they close their mouth, you look in, and if the teeth aren't lining up right, and they used to line up right, that's a real problem as well. The mandible tends to break mostly along the body and the angle, but also up at the temporomandibular joint, the condyle, where it goes into the temporomandibular joint. That breaks quite a bit. So those are the areas of tenderness. Over the TMJ, right at the angle where the jaw goes from up and down to forward, and then along the body itself. And again, if you think they're broken on one side, check the other because they're probably broken there as well. How do you treat these? Well, remember, these are an airway threat. There can be a lot of bleeding, so give the patient suction. If you're not worried about a C-spine injury, seat them upright. If you are worried about a C-spine injury but they're having a lot of bleeding and trouble maintaining their airway, then put a KED on them, a C-collar set to low so the jaw can hang open, and sit them upright, immobilized. You can put on a Barton bandage if they're not having trouble managing their airway and there's not a lot of bleeding, which is basically a bandage around the head and under the jaw, what supports the jaw. If it's an open fracture, they need antibiotics. They're going to need pain control, and you're going to need to evacuate them. There's not much you're going to be able to do for a broken jaw. The question is it emergent? That is there an airway threat? Or is it just that it's broken and uncomfortable, and in which case it's an urgent evacuation? But if they have to stay shipboard, they'll be safe, they just won't be functional. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your instructor or professor. Thank you very much.